Well, good evening, everyone. I hope you can all hear me. I'm Tushar Nafde, Country Portfolio Manager at Pfizer in the gastrointestinal, pain, and inflammation therapy areas. Welcome to you all, and thank you for taking the time to join us today. This is the first of a series of webinars sponsored by Pfizer called ERCP Masterclass. ERCP being a very difficult technique to master, this masterclass would focus on covering the practical aspects of performing ERCP in three different lectures. How to do ERCP in a simple case, how to do ERCP in a difficult case, and how to do ERCP when standard measures have failed. Today's first lecture would be on how to do ERCP in a simple case. This concept of ERCP Masterclass is a brainchild of our speaker for the series. It's my privilege and pleasure to introduce Dr. Malay Sharma. By name, I think most of us know him very well. He is the director, consultant gastroenterologist, hepatologist, and head of endoscopic services at Aryavart Hospital, Meerut. He completed his MBBS and MD from LLRM Meerut and DM Gastro from CMC. His key achievements include ASGE Audio Visual Crystal Award 4 times for prediction, prevention, and management of post-ERCP pancreatitis in 2021, prediction, prevention, and management of post-ERCP perforation in 2021, prediction, prevention, and management of post-ERCP bleeding 2020, and EUS of lung cancer 2017. He has to his credit more than 100 national and international publications. He has been faculty at international conferences from 2004 to 2018 in China, Nepal, Malaysia, Philippines, Thailand, Sri Lanka, France, and Italy. He has been a course director in many international workshops on EUS. So with that, welcome to all of you once again, and I'll hand you over Dr. Malay Sharma. Thank you, sir. Welcome, sir.
Thank you very much. So how I do ERCP in a simple case? Well, nothing is simple when it comes to ERCP. And in this lecture, my job is to make it simple. But to explain that, I have to explain what is complicated. This is a case where we have done multiple stenting, but the bile leak continued, and we found out that after PTC that this was the bile duct, and we did a fistulogram, so bile was going into the right posterior segmental duct, which was totally separate from this duct. And into this duct, somehow we were able to patch in a guide wire by PTC through the external route, same guide wire, and then into the duodenum. And then we pulled it, the guide wire, and then we stretched it from both sides, and we could reanastomose the disconnected duct into the main bile duct. So this is what I mean by difficult ERCP. This is a movie, The White Crow, and this is a sentence, famous sentence, in which when he's telling him how to dance, that his steps follow and belong. They are not done in haste. They have a logic and they are interconnected. So when we are doing those steps, we are trying to prevent these three complications. And with that in my mind, I want to explain what are the ergonomics of ERCP during positioning, how to stand, how to move, how to position the papilla, how to cannulate, how to cut, how to move in and out of bile duct, and many more things about ergonomics. The sense of ergonomics is important because we have to have position of patient, position of operators, and the movement. These are the three steps. So the ergonomics are getting more and more important because the body acts. The position of patient can be prone, semi-prone, or supine. I've done most of the ERCP in prone position or semi-prone, but the principles remain the same. Open position to the left. When we do, the operator initially faces the patient's feet. Open position to the neutral position, the operator faces the patient. And then when in a neutral position, the greater curvature is visualized. I will explain more. And in an open position to the right, the operator faces the head of patient. So when I'm standing this way, I'm facing the patient. and this is open position to the right. So I'm going to explain these three positions, and ultimately when I reach the duodenum, it's open position to the right. I'm standing like this, my patient is lying like this. This is an open position to the right because the medial wall has duodenum. So for movements, we need a combination of pour, in and out, rotation of the hand, up and down knobs, and left and right movement. And with the combination of these four movements, we aim to reach the duodenum. The first thing is how to go from esophagus to stomach. I've divided this into many small steps. How do you position your body during introduction of scope? Introducing the scope, going past the tongue, visualizing the hypopharynx, entering upper esophagus, going through the esophagus, and negotiating the lower end of esophagus before positioning of scope in the stomach. These are small steps. So these steps are subdivided, but basically you have to engage in piriform fossa and enter into upper esophagus. You can enter either the left piriform fossa or the right piriform fossa. Generally, we more often engage in the left piriform fossa, the scope for esophageal intubation. And then what do? We just push the scope forward and lift. This is the. So you are doing two things, pushing and moving it forward. Or if you cannot do it, go into the right piriform fossa and then you're moving to the other side. Both ways, forward push, accompanied slight forward push and rotation of the scope. Because a perforation can occur into these piriform fossa. If you are forceful, you are not slightly rotating and just pushing because this push has to give away. You have to feel that you are going. And this is what happened, that hypopharyngeal perforation, 60-year-old lady, too much of push was done, difficult intubation, and there was some mucosal trauma after the ERCP. There was neck, hoarseness of voice, and this was the picture. The left vocal cord was not moving, and there was some area of swelling around this. CT scan showed that this was the air which has leaked out of into the retropharyngeal space. Anyway, the patient improved. I merely want to show that many of us do not go for CT scan. The patient is okay, and these retropharyngeal perforations generally improve, as this patient did, advancing up to the gastroesophageal junction. You advance slight clockwise and anti-clockwise rotation. Do not just push. Why? Because and slight downward movement. One, visualize the lumen of the esophagus as you are advancing it into the towards the lower end. Give you some example. 45-year-old lady, ERCP done, duodenoscope could not be advanced, and then we found a perforation on endoscopy, and an esophageal stent was placed to manage this perforation. Another case, the consultant encountered resistance during negotiation, and this is what we found, that there was a stricture. So this was just an incidental finding. Does not mean that always endoscopy should be done. The lesson is slowly feel the scope going. Again, in this case, an expandable stent was placed to cover the perforation. This is at gastroesophageal junction. You have to be more cautious because in this case we did an EUS and ERCP, and while removing the scope, we found a blood clot in the hiatus hernia, and attempts to clear the clot failed. It was difficult to decide whether this injury was transmural or not, but perforation was suspected in this area, and then and over the scope, this was the clot. Clip was applied to manage this perforation. And this is how the perforation happens in hiatus hernia, where you are going in the wrong place, pushing it forcefully. So negotiation across the GE junction should be done carefully because these are the two possible sites of perforation. And as we see, this is because the intubation related perforations, this is can occur in the area of resistance, narrowing, or pathology. Do endoscopy first. This is an ascaris I am showing. Because I want to emphasize that you have to move like an earthworm. Slowly, you want to reach to the lower end of the esophagus. When we come moving from stomach to pylorus, these are the three steps. You suck the fluid, orient towards the antrum, and advance towards the pylorus. Suction of fluid is essential, and the scope is advanced toward the dependent part where you suck all the fluid. Orient toward the antrum. What you need to do is slight push and rotation of the scope to the right, turns the tip to the right side. Scope gets oriented towards antrum, and the folds are followed by flow forward, rotation, and continuous up movement of the tip. Again, in three things: push, rotate, and move. Please, you will orient towards the antrum and proceed advancing towards the pylorus. This should be done with slight downward angulation so that you keep on seeing the pylorus. But once keep the pylorus, reach near the pylorus. So I can show you how the injury occurred in these steps. 45-year-old lady, removal of scope, blood seen near the lesser curvature, and this is a tear which occurred along the lesser curvature. The bleed is stopped, we required no further management. This figure shows again the mechanism of injury. The scope was blindly pushed beyond the G junction and resulted in tear of the lesser curvature. The video shows how you position the scope towards the antrum. You slide along the lesser curvature. The most important step so showing again clockwise rotation of about 90 degree, up movement of the up knob, and a push of about 15 to 20 centimeters from the OG junction. Once the scope goes near the antrum, we should suck the air. While you're doing this movement, stand, and when you reach near the antrum, then you suck. Some small, finer steps, advancing towards the pylorus, just positioning, entering the pylorus, and not slipping back once you enter the pylorus. This is the famous sun setting sign pictures that as you are advancing towards the pylorus, it should look like a setting sun. And the concept of upper and lower lip of pylorus must be clear because you are going to go in a way that the lower lip comes at around 6 o'clock position and then go near, engage. Sometimes by pushing you cannot go in. At this time, do not forcefully push. Keep it near the lower lip. Move right and left knob. Move whole body slightly clockwise and you will enter. Not slipping back after entering the pylorus is an important thing. So what you do after slipping back, once you enter, do slightly push more, just about 5 millimeter, and rotate your body clockwise so that you don't slip out. Now I am going to mention the steps of duodenal intubation in 4 steps with the mnemonics base, bulb entry, advancing across D1, D2 junction, shortening, and end-phase positioning near the ampulla. Because it is at these 4 places perforations can occur. I would like to briefly explain what is the concept of intraperitoneal and retroperitoneal perforation. All perforations are associated with leak of air, and the endoscopist should be familiar because this is duodenum has 4 parts. First part 5 centimeter, second part 7.5, third part is 10, and fourth part is 2.5. The first 2.5 centimeter of the first part of duodenum is covered anteriorly and posteriorly by peritoneum as it happens in the stomach. But perforation of proximal 2.5 centimeter duodenum in its anterior surface open into the greater sac and its posterior surface open into the lesser sac. Whereas rest of duodenum is not covered by retroperitoneum and the air goes into the retroperitoneal cavity. So how this behaves differently? Because this figure shows retroperitoneal air, and do you see that this retroperitoneal air has gone near the liver? And this air shows the intraperitoneal air, which is in an anterior posterior diagram seen mostly in the anterior and inferior aspect. How does this look? When we see the figure, this is air under right hemidiaphragm. And initially it looks that this is intraperitoneal perforation. But careful review shows that there is a line here around the kidney. And this is a retroperitoneal perforation. So this perforation occurred during ERCP. Although a metal stent was placed to cover the perforation, but this is an X-ray showing here. And this is what happened after 48 hours, that this air under diaphragm is still present, but rest of the air has been absorbed. On the other hand, this perforation is happening more laterally. And in this case, we can see that lateral X-ray is intraperitoneal perforation. So gas under diaphragm can be both intra and retroperitoneal perforation. And the management is different. Small 4 steps when we are advancing the scope, D1, D2 junction, entering the D2 in a long loop, and remaining in the D2 in a short loop as entering from a long loop to a short loop position. So 2 key movements. The first is negotiation across the D1, D2 junction to enter into second part of duodenum. The second is deep intubation almost into the third part, because you can see the inferior duodenal angle, as in this case we are seeing the inferior duodenal angle now. The engagement is facilitated by right and left knob of the knob, upward movement of up and down knob, clockwise rotation of the shaft, and slight pulling back of the scope near the duodenal angle. And you see, we always try to maintain endoscopic view when we are doing a combination of these movements. So this combination brings the scope into a short loop position of about 55 centimeter. And I would like to explain what is the difference between the fiber optic era. Because in fiber optic era, you are just torquing the scope and you used to keep your wrist flexed, standing like this. But when the video era came, you were able to rotate your body like this. And these are the 4 differences that we can see that wrist flexion could be avoided, and fiber of video scope allowed more flexibility, and they also decrease the risk of perforation. And we can rotate the body as we enter into the second part of duodenum. So I want you to understand, for me, it is mandatory when you are in the second part of duodenum to remain stability. You should rotate your body like this. This negotiation across the D1, D2 junction is done carefully under complete visualization and slow clockwise rotation. Shortening the scope by pushing the hand inside and periodically pulling the shaft back. The right hand can alternate like pull back, shortening slowly. Do not hurry. Do not do the jhatka. Do not do the fast maneuver. Shorten. This is again carefully stretching about the D2 junction. Push toward the and slowly rotate the body. You will see the bulb. Because if you don't do it, this is where you are going to cause perforation. Shortening more explained, right and left dials can lock or maybe not lock. But complete visualization and the pull out will place the scope beyond the ampulla of Vetter. If you do it fast, this is the possible site perforation. I want to explain a crisscross movement. What is crisscross? The hands are crossing. This is like this, they are crossing. And this crisscross is important because one hand is stabilizing the scope, the other hand is shortening the scope. And this is what I mean to wait. Crisscross is that this one hand is stabilizing, keeping the scope stable. And the other hand is shortening. But it is coming from inside. Crisscross in the space between the scope and your body. This crisscross movement I consider when the hand is coming between the body and the scope so that the scope gets shortened. This is important because this pull out places the scope into the second part of the and this should be done slowly and slight upward movement of the scope, slight upward, because otherwise if you don't do it, it can cause perforation. So you have gone to the third part of duodenum, and this is the last part that you want to bring the ampulla and face towards. And when we bring the ampulla and face, again slow continuous withdrawal is required. If the scope slips out in lock position, the chances of perforation are high. What is called an ideal position? I would say an ideal position is where my papilla is placed in the right upper quadrant. But it is in this situation I will be able to do the. So I want to prevent perforation. As I said, the explanation of all these ergonomics, everything is I want to prevent complications. And though there are many smaller steps, I have given a lot of stress on the ergonomics. You do sphincterotomy in correct access. The guide wire definitely helps, and this is no longer such a big problem that which axis you are cutting, because if the guide wire is in the place. But yes, sometimes you have to do readjustment of the axis. Keep 1/3 of the sphincter inside. Do not push a lot of sphincterotomy inside to avoid cheaper cut. I will show you this example, cholangitis and shock. Biliary sphincterotomy was done, and this is what happened. So this was the intact duodenal fold, and a perforation was noted, and a stent was placed. And this is how it happened. But the sphincterotome was too much inside, too much board inside, and it cut this. The excessive bowing of the sphincterotome may cause this kind of perforation. And so there is no need to bow it so much. I want the sphincterotomy generally tailor-made to the size of the papilla. I am showing this some small papilla and also to the size of the bile duct. The bile duct, these are the different examples: small and large papilla, small and large bile duct, small and large sphincterotomy. You must add sphincteroplasty if you want to remove a large stone to avoid complication. Do a sphincterotomy and add sphincteroplasty. Be careful when you are introducing, because if you introduce the accessory in the wrong axis, you can create perforation. Do not be careful not only in entering, be careful during removal. So though this balloon was removed slowly, but if you were to remove this balloon fast, not coming out, deflate it slowly. So this is what happened, that the patient came for repeat ERCP and the removal of the stone. Stent was removed by a balloon sweep, and you can see that the perforation. There is no fresh incision in this case. The power of balloon was so much that it tore the sphincter. The use of force by balloon can cause perforation. We should be selecting proper accessories, either balloon or guide wire. This table just shows small comparison between the balloon and basket. And use proper maneuvers for removal. First, right and when you have caught a stone, first move right and left knob to the right. Up and down movement, move downward. Slowly it goes downwards. Scope is rotated slightly clockwise, and you do clockwise torque. And then scope can be pushed downwards slightly towards the third part of duodenum so that the stone is delivered. So this sequence of movement is required to take a stone out, and the opposite is required when you want to go in while doing pushing the stent or while pushing in a balloon or basket. So this maneuver transfers the force in the correct axis. But the success rate, ERCP, depends on your ability to judge when you want to do pre-cut, how you want to, and the adjustment of the length of pre-cut by the assistant. ERCP was done, a pre-cut was done after placing a pancreatic stent, and a perforation was noted. A clip was placed, and then after 3 days of antibiotic, ERCP could be done without any complication. Be careful when you are placing an endoclip in a case of near the sphincter, because it should be done by after saving the pancreatic sphincter, as pancreatic duct clipping can have serious consequences. And the technique of application of clip is you first go push the scope near the inferior duodenal angle, take out the clip, and then you push. Open clip is pulled back, scope is brought closer to the sphincterotomy side, you move the knob up, you lift the elevator up, and then you apply it at the side of perforation. Small addition to your technique of pre-cut, use the help of respiratory movement. As seen in this case, we are cutting when with the respiratory movement, this cup closer to the papilla. So this is a case, ERCP was done, sphincteroplasty was done, and a perforation was noted during the clearance of the stone. And a spendable stent, covered stent was placed to manage the perforation. I am showing the complications simultaneously because you have to learn how to manage the complications when they happen. If you want to do good ERCP, complications will happen inevitably. But be ready to manage these complications, whether they are perforations near the papilla or whether they are perforations away from the papilla. So as we are doing pancreatitis, as we are doing ERCP, One of the thing to learn is how to prevent pancreatitis, and avoiding diagnostic indication is the single most effective. We must evaluate marginal indication, because if don't do ERCP, not indicated, and only if it is indicated we do it, because an ERCP done without evaluation with a questionable indication is the single biggest cause of lawsuit in the world. Even in India today, this is the single biggest cause. ERCP 62-year-old female, dilated CBD, calculus reported, but LFT were normal. Anyway, we went ahead, and once we found that there was a diverticulum near the papilla, came out, we were still not sure of the stone. MRCP showed this finding that there was a CBD, PD, and a diverticulum. ERCP was cancelled. So just because you can do ERCP does not mean that you should do ERCP. It is never too late. Select only therapeutic indications for ERCP. This is an obstructive pattern, type 1 SOD, pancreatic duct dilated, and bile duct dilated. So we have to establish the correct indication. And again, as I said, evaluate marginal indication. And the common marginal indications are related to gallstone disease, sludge, microlithiasis of bladder, macrolithiasis, sludge in gallbladder, or sludge in the common bile duct. 45-year-old male, biliary colic, dilated pancreatic duct, and this is what we found, that there was a stone in the pancreatic duct and a stone in the bile duct. And both were seen on ERCP and both were removed. You can see the contour of pancreatic duct is sort of a normal contour. It does not look like a chronic pancreatitis. And this is how one of the stone of bile duct slipped back to the pancreatic duct. Again, 46-year-old lady, first episode of pancreatitis, normal CBD, transaminitis. Patient was advised cholecystectomy before discharge. These were the values. The patient made a request that, look, I had a very severe attack of pancreatitis. Fine, whatever you're saying is fine, but I want more evaluation. So we proceeded with endoscopic ultrasound, and this showed a 2 millimeter stone in the common bile duct. What does it tell us? And sure enough, in ERCP, it was removed. So the guidelines were not indicating that you do proceed with it. This stone may have passed out itself, or this stone may have created more problems after cholecystectomy. But personalized medicine is important, and do not be stubborn in following the guidelines. Do pharmacoprevention by giving indomethacin or diclofenac suppository, and this is the recommendation for low or high risk. High risk case must receive rectal suppository. So how can we prevent pancreatitis? I will just discuss some of the steps in these cases. Check accessories, and the consultants must check accessories. Attempt wire-guided cannulation always, because this is the recommendation today. And stop. More than 5 attempts, more than 5 minutes. You have to define this is difficult cannulation, because this is an independent factor for pancreatitis. And once you have defined, okay, this is difficult cannulation, you have to do 3 things. Either you have to persist, or you have to do needle knife, or you have to find out in this 5 times that guide wire is unintentionally gone into the pancreatic duct. Now you proceed. Now, so far as persistence is concerned, frankly, I am not the one person who persists, but there are people who would persist for another 5 or 10 minutes. Can be successful, but meta-analysis has revealed that early pre-cutting is more effective. So going back, 3 things: persist, needle knife, or unintentional guide wire slippage has occurred into the PD. And we have to decide what to do. So I will use a needle knife by fistulatomy or pre-cut, and this is how I will to proceed. But I want to define what is my end point of pre-cut. In the very beginning, in your mind, decide the end point of pre-cut by slowly moving. This is the end point of pre-cut. And the pre-cut can be from above downward, both ways. So what is the difference? One is from known to unknown. You are cutting from papilla above, or from unknown to known. So who can do? Anyway, now this is where I think those people who want to do ERCP must do pre-cut. Although Peter Cotton once said that this is a risky procedure, but if you want to learn ERCP, you must be trained and you must know how to execute pre-cut from unknown to known and known to unknown. You can do a fistulatomy or pre-cut. So in the meantime, as I said, what about guide wire removal? Your guide wire has gone into the pancreatic duct. Do you remove guide wire? I promise, never. Never remove a guide wire, even if it has gone once, because if you do not protect the pancreatic duct, it is associated with higher morbidity. And today it is my policy. If the guide wire has unintentionally gone into the pancreatic duct, even once, I place it. So recommendations are that you should place it sometimes once, sometimes twice. But if I have entered into pancreatic duct, I will place a stent. And the pancreatic guide wire reduces the procedure time, increases the convolution rate, prevents contrast injection into the duct, and placement. But be careful, because the pancreatic stent can go through and through. This can fail. So if the guide wire has gone, if you do not know how to do pancreatic stenting, you should not do ERC. At least I would consider a simple ERC. Pancreatic stenting is mandatory, because if you want to bring yourself in pre-cut group, learn pancreatic stenting, both pre-cut. Intentional cannulation of pancreatic duct to facilitate biliary cannulation is not recommended. So your guide wire has gone into pancreatic duct. What do? One of the three things. Either place a pancreatic stent, or you do transpancreatic sphincterotomy, where you cut the sphincter a little bit, or you do double guide wire technique, and that is what we will show. But first, let us show how you should do the pancreatic stenting, and what is the technique, what type and stent, how long to keep the stent, and what to proceed. This is the technique of pancreatic stenting. You do it, place, and as soon as you push it, rotate, push it, as soon as the black marker comes, you stop pushing. If the guide wire has gone up to the neck, place a short stent. If the guide wire has gone beyond the neck, you place a long stent. So this is the difference between short and long stent for cannulation. How long to keep the stent? You never remove the stent in an early phase. You do an X-ray at 2 weeks, and either the stent has passed out, and then you remove. The question is, after pancreatic guide wire entry, should you place stent first, or you should do biliary intervention first? I will show some cases. ERCP 1.2, the guide wire has slipped into the pancreatic duct, and then the guide wire is in the bile duct. So we place the stent in the CBD, and then we place a stent in the bile duct. But it could have been done whichever way. This is the bile duct stent. The problem is you should be careful, because you cannot afford to slip out. This is the guide wire in the pancreatic duct, guide wire in the bile duct, both ways. And we have to find out pancreatic stent, if you have an intentional guide wire, transpancreatic sphincterotomy, or double guide wire technique. These are the three techniques. How do you transpancreatic sphincterotomy? To keep the guide wire in pancreatic duct, turn the whole body slightly to the left and cut the sphincter a little bit. This is the technique of transpancreatic sphincterotomy, the guide wire inside the pancreatic. This is double guide wire technique, that you leave one guide wire inside the papilla and then you sort of push the guide wire a little bit. And after pushing the guide wire a little bit, then you pass in another cannula. The papilla is now lifted up and you pass the second guide wire into the bile duct. So this is my summary, that you've defined difficult cannulation. The only question is between transpancreatic sphincterotomy and double guide wire technique, which one is safer? Anyway, to each his own, whichever you are more comfortable with. So this is ERCP resulted in bleeding, and this is the tapered cannula. You were able to inject with the tapered cannula a little bit of adrenaline in this area. And this is the pancreatic stent has been flayed. Injection of epinephrine was given into this area and the bleeding stopped. So now I am explaining the third complication of ERCP. So we have discussed till now the ergonomics, the management, what we are doing, how we are proceeding with ERCP. And as we are doing ERCP, we are preventing the complications and we are managing the complications if they happen. And the bleeding can happen because this is the third complication. It can be immediate or delayed. The bleeding can be small, tickle, spurt, gush, and there are many things which can worsen it. But we must sometimes, rarely, we must say, once in a year, means in maybe 2 years now, we have to inform surgeons and intervention radiology people. But lately, we have been much more successful, and we have been able to define bleeding into several grades. These are the concepts that I want to explain to the people, define what is the grade of bleeding, define how visible is the area of working, what you can do, specific point of bleeding, it is an exposed, unexposed edge of the region, right margin of bleeding, left margin of bleeding. Sometimes the bleeding can be delayed. So immediate assessment, this clinical assessment that has been given in the books is not good. It doesn't help me. Mild, moderate, and severe, because this is a delayed assessment. I want an endoscopic assessment, and I use personally a Bozart scale which is used by surgeons for quality of surgical field of vision. And in this scale, bleeding is divided into 6 grades. 0 is no bleeding. 1 is slight bleeding when you don't use any suction. 2, this is an example of very mild bleeding. You don't use any suction, this bleeding is going to stop. And most cases of ERCP related bleeding are related to accessories, and we use devices against slight bleeding. Now this is grade 2 bleeding, where you are occasionally doing suction. Slight bleeding, occasional suctioning is required. Then frequent suctioning is required because bleeding threatens to interfere your field of view if you remove the hand from the suction. So this is grade 2 and 3 bleeding are required. Grade 4 bleeding is that bleeding is immediately if you remove the suction, the bleeding will interfere with your view. And grade 5 is when the bleeding is faster, then it can be suctioned. You do not get a view at all, and this is grade 5 bleeding. So I will explain. So the difficulty of therapeutic intervention with 0, 1, and 2 is minimum. 3 is slight, 4 is great. Grade 5, usually it is impossible to do therapeutic intervention. So this is the scale I use and for management of bleeding. The effect on visibility, the difficulty of procedures, and this is how we. But we must do whatever we do because improvement in visibility is required. We must decide whether we want to improve visibility, we don't want to improve. So immediate assessment is useful. Sometimes you can wait because if the bleeding is mild, you wait. There is no need to do anything. You have just done a sphincteroplasty. The bleeding is going to stop in a minute or 2 minutes, and waiting should be continued if it decreases. But in the meantime, when I'm waiting, I want to maintain and assess. I have to decide in my mind, this patient is having bleeding. Should I place a stent first? I will place a stent first because my guide wire is in place, the bleeding is continuing, and then there is I will be able to have a secure access. And once the access is secured, intervention in management of bleeding is required. Bleed occurs, immediate intervention. And this is a plastic stent was placed, bleeding happened, stent placed, and then you can use the needle for injecting adrenaline in the area of bleeding. You can do blindly. So access is maintained by guide wire. Sometimes you do extension of sphincterotomy because sometimes you wait, but there is little margin of error. If you lose view, face fully covered expandable stent. If you are not good, if you are not sure of your ground, if you are inexperienced, and if there is bleeding, you can place fully covered metal stent immediately. But how do you regain visibility? Number one is regular suction, and there are several things. Clot clearance, maintenance of SS, and continuing of ERCP. These are the 5 smaller tricks if you do not have visibility in bleeding case. Now this is continuous with techniques of regaining visibility. We continued the procedure. There was balloon guided removal, and we kept on removing the stones with the help of balloon. The bleeding stopped after the irrigation. But one problem will happen. The clots will form over the stone, and clot clearance is frequently required, and bleeding. And this is again as so several. So this is bleeding from right upper edge, 45-year-old male, mild reduced visibility of the ampullary area. Dilemma was to secure access or to proceed with endotherapy. What to do? Anyway, stent was placed first, access was secured, and then the bleeding was. So this slight ooze was continuing, but endotherapy was possible because we had secured the access. So inject before vision loss occur. Inject into edges, inject above edges, re-inject if needed, inject blindly, and combine injection with other tamponade. What are the other tamponade? Balloon tamponade from outside, you can do balloon tamponade from inside. This is a mild use, sphincteroplasty, self-limiting. This is partially severed artery, and then we increase the sphincterotomy because the bleeding continued. We increase the sphincterotomy, bleeding continued. Injection of adrenaline, balloon tamponade, these were the options. The massive bleeding will require multiple stents. I will show in this case CBD stone, cholangitis, renal failure, hemodialysis, underwent ERCP, and biliary sphincterotomy induced massive bleeding. Severe and continued bleeding and a pregnant lady. So these are the cases, and the clots were covering the sphincterotomy. So we had secured us, but the clots covered this. We had to remove these clots, and after removing the clots, we were able to inject adrenaline at the correct place. So difficulties of injection can be there, and this is a but you must see the bleed proceeds either at 6 o'clock position, or if the patient is supine, it will proceed in a different position. it will proceed at 3 o'clock position. So tamponade can be maintained by balloon. Balloon can be inside the bile duct. Balloon can be outside the bile duct. So this is balloon, you inflate and you press it against. So this slide summarizes the management of severe massive bleeding in carotid artery. Massive bleeding, this is the option, but if you have severe bleeding, good. So as I said, for the bleeding, we have in the last 2 years, we have not required any surgical intervention. Rather, almost 5 years, we have not required any surgical intervention, and all bleedings have been stopped. We have placed about 3 expendable stents in bleeding. We have had about 100 cases of bleeding so far in the lab. The summary is the lecture is you must anticipate and prevent problems. Be consistent and methodical in your approach. Do not panic. Go slow. One of the stalwarts once said, if a complication has happened, just leave the scope in the hand of your assistant for a minute, only for a minute. Take a deep breath. Okay, this has happened. And then start your work. And this is how we have to learn how to do endoscopic ultrasound. So though I went on in this case, and there were many aspects how to present this difficult lecture, how to do a simple ERCP, but I have emphasized a lot on ergonomics. I have emphasized a lot on complications. So, now I am looking forward to your questions if there are any. So, this is it. Thank you very much.
Thank you, sir. It was a very wonderful and insightful lecture. In fact, thank you very much. And you covered a huge amount in different interesting cases. Um, there are questions, a couple of questions, sir, which I put in the chat. Um, there's one question from Dr. Wahid from Kazigan. ERCP is restricted to tertiary care hospital. One, its main poor indicators.
So see, ERCP is related to tertiary care. I am having the questions now. I will keep on answering.
Yes, sir.
So this is from Quasigund. Okay. You must do it. The problem is you must know have two things. Number one, ability to do pancreatic stenting, ability to do pre-cut, and ability to place an expendable stent. You must have these three things: expendable stent, pre-cut, and so then you can do ERCP wherever you are. Next question is Ashish Kumar Patel. Facing Dicaldine engaging papilla. I think I have already established that you must position papilla. The papilla must be engaged. Papilla can be engaged tricks to overcome it. Okay. So how to engage papilla in a proper position? The papilla can be first must be brought into the right upper quadrant. And when I say right upper quadrant, I have already emphasized upon the crisscross. What I mean by crisscross is this hand is going to stabilize the scope and this hand is going to push the scope inside or outside. So this is crisscross. Once learn, never put the scope this hand outside the scope. Always crisscross. So this hand will stabilize the scope and this hand will push the scope into the duodenum. And this will place the papilla in the right upper quadrant. So this is number one trick. Okay. In between, you keep on moving your scope. Papilla may come down. Again, do crisscross. Second trick is, once you are passing out the stentotome, keep it up. keep the elevator lifted up with the base of the thumb. This is the base of the thumb, and move up and down now with the tip of the thumb. So this is, I call 2x2 principle. You stabilize the elevated part of the cannula sphincterotome and you stabilize the upper thumb. So you can move the elevator up, you can move the up knob up. You can move the elevator down, you can move the up knob down. This hand is stabilizing. So I understand, Ashish, that you are in the beginning, and second is try with the guide wire. So there are many things I can tell in engaging the papilla, but to summarize it, bring the papilla in the right upper quadrant. And once you have brought the papilla in the right upper quadrant, then take the sphincterotome out of the scope. Once you have the sphincterotome out of the scope, keep it lifted with the base of the thumb. Keep your body like this, rotate like this end, and then pass in the guide. What should be the approximate depth of needle in mucosa to start with a safe pre-cut? Yeah. When you're doing a pre-cut, the papilla is jutting out. Initial depth can be more, but as you keep on extending the pre-cut, you should reduce the depth. So because it is your assistant who is holding the pre-cut knife, he will adjust the pre-cut. Several more things, because though this is part of the next lecture, but how pre-cut is done in layer by layer. You do first layer from above, below, or above down. When you have done the first layer, it will be slightly opened. So what you do is you press the needle again into the exposed part, and then you move it up, sort of flick it outside. So you are doing not exactly a pre-cut from below up, you are doing from inside out, not doing into it. Do not poke the needle. You are doing an inside out pre-cut. This is safer. So the concept is below upward pre-cut, keep on reducing the needles of pre-cut, and as you are going below upward, once it has opened, inside out pre-cut and towards the upper edge of the papilla. So this is the answer. Approximate depth of the needle should be adjusted by your assistant, and that you have to train your assistant that as I keep on moving in now, you slightly reduce the depth of the needle while you are doing. Maneuvers to cannulate the papilla. This is Kshitij from Rishikesh. Okay. Maneuver is number one, you must engage in the papilla. You have to learn how to engage the papilla. Once you have engaged the sphincterotome in the papilla, then you can move either right and left knob. You can move up and down knob. More often, I move up and down knob. You can torque the scope a little bit like this. So, papilla engaged. After engaging, we want to cannulate. We engage and then we will cannulate. So, after engaging, move up and down, move right and left, move this and this, move whole body to left. And then once you are engaged, then you will learn how to go from a long loop into short loop. That you push the whole scope inside, move to left. You have to learn how to go for push the whole scope inside, move to left. But all the time, cannula or the sphincterotome must remain engaged within the papilla. Now to understand, while you are doing this right and left, up and down, or torquing the scope, or moving from long to short loop, or short to long loop, pushing in or pulling it out, the cannula is there. and your assistant is rotating the guide wire. Is pushing the guide wire. So the axis is changing continuously during this action. While you and what you are looking is for axis to it should slide like this into this direction. So these are the maneuvers to cannulate the papilla. Now, how to extract large stones if lithotripsy is not available? This is Dr. Haytham from Egypt. Okay, we have in India, means at least at our center, we have evolved a concept of sacrificial lithotripsy. We have baskets which are available to us for a cost of about 2,000 Indian rupees. That is, say, roughly around $30. And these baskets we put in inside the bile duct, we catch the stone, and we cut the basket and crush the stones. We crush 2, 3, 4 baskets. It is much safer than putting in the conventional Olympus lithotripter through the scope, because Olympus lithotripter puts in a lot of damage on the sheath of the scope when you are crushing it. So we remove the scope, and large stones, if lithotripsy is not available, doesn't matter, they will be caught. But there is a trick, Miss Dr. Haytham is asking, why, how? Because in Egypt, I believe there are a lot of large stones. Okay. What is the largest I have removed? I have removed several 5 centimeter stones from the bile duct. Now the trick is that sometimes you take the basket up, it will make a loop. It will not open, it will make a loop. And then you cut the top edge of the stone. Then you cut and you crush that. The basket, cut the basket and you crush that. So you keep on cutting the stone in multiple lithotripsies of the same stone, and we have had opportunity that we cut 5 baskets in cutting a single 5 centimeter size stone to many small pieces before they can be removed through a sphincterotomized and a sphincteroplasted CPD. So this is the trick to remove large stone. Remember, the large stones sometimes can be very compactly impacted within the bile duct. There will be no room. Never bother removing the lowest stone because it will not be caught. The trick is try to send the basket higher up. Okay, if you cannot send the basket higher up, what technique we have evolved is we take a small guide wire, we place an intraductal CRE with 4 or 6 millimeter balloon, and we facilitate the intraductal CRE within the bile duct, and then we pass in the basket. It goes more easily after a space has been created within the bile duct. So you create intraductal CRE, pass the basket, catch the top part of the stone, and then the rest of the stone. The stone will be clear. Other technique is sometimes if you are caught, the trick is catch the lower stone, catch the upper stone. Sometimes you catch the upper stone by the basket, and when you do the lithotripsy, the rest of the stones slow down, are softer, and they get crushed. Steps for successful PD cannulation is the next question. The steps for successful PD cannulation are, okay, you are standing this way, engaging papilla, you will go like this. You are standing this way, engaging papilla, you will go into pancreatic. And that is the basic. The way you engage your cannula and the way you turn the scope after engaging the cannula will decide. If after engaging cannula, you are moving clockwise, you are more likely to go into pancreatic duct. If after engaging into the papilla, you move slightly anti-clockwise, you are more likely to go into the pancreatic duct. So this is also probably once upon a time when I used to do ERCP, how would I know that this is proceeding towards pancreatic duct? So when the cannula had gone and I didn't want to use fluoroscopy so much, the way the cannula curve, if it curves like this, it is going towards pancreatic duct. If it curves like this on pushing, it is going to the bile duct. So these are the steps of successful pancreatic cannulation. Supine position of ERCP, endoscopy position. So this is Dr. Shatri from Abu Dhabi. Hello, Dr. Shatri. Nice to see you are on the scene. So the endoscopic position, the basic difference is that when the patient is prone, I'm standing like this. When the patient is supine, I'm quite often like this. Or sometimes almost like this, almost opposite side, almost away from the patient. Now, in this trick, I would like to explain a smaller technique to the beginners. Okay. For this, I will just stand here and make myself stationary. And I will turn my neck. No? Right. Now, what I will do is, I will, instead of this, I will adopt a posture like this. I will turn left and right. So what I believe it is mandatory that when you are standing, you should stand with your legs forward like this. So that when you are turning, you should be able to turn. And you can see my face all the time I am turning. I will be able to see the screen where I am. And because now I am turning my whole body to left or whole body to right. And this is imperative that you must learn to stand during ERCP with your legs apart with a gap of about 2 feet. With your knees bent knees, then you are moving your body. This will also distribute the load to all different joints of the body and will do less damage to your body if you want to do ERCP for a longer time. So a boat position with slight legs apart and rotation can help you see the screen wherever you are, whether you do it supine position or prone position during. So this is the right topic here. Dr. Ajay Patwa, you asked a question, simple presentation. And I appreciate that this is a simple presentation and this is simple. So I hope we are done with the questions. If there are no more questions, I think we can take a leave here.
Yes, sir. We are done with the question, and so thank you, sir, once again for answering all the queries posted by doctors connected on the webinar, and I'm sure all the doctors connected. We counted around 418 doctors who are connected across India. Would have updated their understanding about the ERCP procedure and how to conduct the ERCP in a simple case here. And we covered a huge amount in different interesting cases here. So also, I would like to thank all the attending doctors, all the Pfizer colleagues, and our technical partners for the success of this lecture. And coming up in the next month, we would have also the second lecture in the series on how to conduct ERCP in a difficult case. We'll soon share the details of the event as well with everyone who is joined here in the webinar. Right. So with this, I would want to declare the end of today's lecture. And thank you everyone, and have a lovely week. Take care.
Okay.
Thanks.
Bye.
Thank you.